So today I'm going to be speaking on robotics and arthroplasty. So when we speak about robots, these are the things that come to our mind. There's so many movies, and we have the good guys, the bad guys. You have the Rajinikanth, and our mind automatically goes there. But this is not what the robot actually look like. Most popular robot, I think, has been there for the longest time is the Da Vinci robot for gastrosurgery. This is what it looks like. But today I'll be speaking about specifically our joint replacement robot. We have the Stryker 4th generation robot, the Mako robot it's called. And I'll be speaking about this in, specific and robotics in general. So does it do everything? That's the question a lot of patients ask us. No, it only assists us. At least this robot, which we are talking about, the Mako robot, it only assists us to make sure that we are not staying outside our predetermined boundaries. We're not cutting more bone than we had planned beforehand. We're not getting any soft tissue injury when we're doing our case. This is an example of the partial knee replacement, the burring, and it has haptic boundaries, and it makes sure that we are not staying outside our predetermined boundaries. As I said before, the surgery is done by us, not by the robot. It's only going to assist us. So it's actually not robotics, but it's robot-assisted arthroplasty. So just to summarize, there's a classification of robots for arthroplasty. We have, depending on the movement, there's a boundary control type, semi-autonomous and autonomous. The boundary control, there is a human interaction and the robot deactivates beyond a certain boundary, but it is actually free to move anywhere. The example of that is the Smith & Nephew Navio robot. And then the semi-autonomous is where there's still a human interaction is there, but it's constrained within a boundary and it's fixed to a robot. So the arm is actually fixed to a robot. And that is basically our Mako robot, which I'm talking about, the Stryker Mako. And then there is the autonomous robot, where there's no human interaction at all. And it's constrained within a boundary like the previous two. And this is also fixed to a robot, but there's no human interaction. Like the Merrill or the Max's Cubis robot is completely autonomous. So just a brief glimpse of the other robots. This is the Smith & Nephew Navio. There's a small handpiece, and you can see that it burrs. You can see that it is burring away the bone over here. And then you have the Merrill Cubis robot. The cutting tool. This is a completely autonomous one. You see the surgeon is standing on the side, and you have the robot completely doing its sculpting on the side. So there's no actual human interaction over here. Okay, but our robot is the Mako. So this is the Stryker, is a semi-autonomous. If you can see, there's a screen over here. The robotic saw, the saw is attached to the robotic arm, but the surgery is still being done by us, if you can notice here. So we are looking at the screen, we're making sure that we cut what is told to be cut. It is auto-aligned and it prevents us from straying outside the boundary, but still we have our own tactile feel of the surgeon. So this is not a semi-autonomous. I mean, this is not an autonomous, this is semi-autonomous surgery. So the Mako robot, the Stryker Mako robot, is the only one which can do all three replacements. There's a total knee, the partial knee, and the total hip replacement. But what's the need? There's wonderful results of knee and hip arthroplasty over the years. But what is the real need for this robotic arthroplasty? So there are three core features. Let's go one by one. Let's talk about total knee replacement first. The three core features for total knee replacement. One is the enhanced planning. Second is dynamic joint balancing. And third is the robotic arm assisted bone preparation. So we categorize these into A, B, C. It helps us to achieve accurate sizing. So accuracy is increased. Perfect gap balancing. So balancing has become like spot on, very objective. And then 100% precise cuts. So once we have determined our plan, it's going to guide us to make sure that we stick to our plan. Our cuts are exactly how we are measured. Even that 1 millimeter or 2 millimeters of human error is eradicated now. So this is enhanced 3D planning. A CT scan is made, and all these films are put together and they're segmented, and then they're combined together to form a 3D model of that particular patient's anatomy. So each case has its own 3D model of that particular patient, and then we do our planning according to that patient's anatomy. So it's completely personalized according to that. So you can flex the implant, you can size your implant. This is all done even before going into the surgery. The next is the dynamic joint balancing. As you can see here, the gaps on the lateral and the medial side, they're balanced perfectly well, depending on exactly what we want. Okay. And then finally, bone preparation. Once you've fed the robot what plan we want to give it, what amount of cut we need to do, it's not going to allow us to stay outside that. We have to remain within this haptic boundary. We don't cut anything more than we need to. And the soft tissues and the ligaments are all protected thanks to this. So now let's move on to the partial knee. This is like sculpting. The partial knee replacement is a technically demanding and slick surgery, and robotics plus partial knee is probably the future, because we have to have sub-millimeter and sub-degree accuracy in terms of partial knee replacement. And by using this robot, we can do the burring, and then we can prevent overstuffing on the opposite, overstuffing on the medial compartment, and prevention of lateral compartment arthritis. This can all be done by proper, precise planning of the gaps and precise burring away of the arthritic bone. And as I mentioned, the medial, lateral, as well as patellofemoral arthritis can be treated with this robot. Then this is just a video of us performing this during the surgery. See, we're burring away, and you can see the accuracy over here. We make sure that we don't stray outside the haptic boundaries. We just remove what bone we need to. Then the total hip in robotic surgery, in total hip replacement, the main challenges are the placement and positioning of the cup, inclination and inversion of the cup, and then of course limb length. All these things can be taken care of by the robot. If you see a manual surgery, if you're going to ream too much, or if you're going to impact too much, you're going to have the risk always of breaching through the medial quadrilateral plate. But here in robotic surgery, it tells you exactly how much of bone you're supposed to ream out, and we don't have that problem anymore. So as I said earlier, inclination and inversion of the cup, limb length discrepancy, all these things can be taken care of, and helps to avoid dislocation as well. So the robot helps to address all these things accurately: the cup size, the femur size, the cup's height and depth, the center of rotation, the cup anteversion, inclination, the offset, the horizontal offset, the limb length discrepancy, and the bone stock. Everything is taken care of in one go by the robot. This is a video of how we do a single ream in the operation theater. You can see the green part is the bone that we need to ream out. And you can see we don't have to do serial reaming to check which is the correct fit of the cup, because it's already predetermined, and we just ream out whatever green is being shown over here. And that's it. Once that's done, we do a direct impaction of the final cup. We don't even have to go for a trial. Okay, just as a brief example, this is a right hip arthritis. It tells us beforehand by giving us a nice 3D model that this is 3 millimeters shorter than the opposite side. Immediately we do our planning. We've decided that 44 mm cup with the 127 degrees stem, size 2 with a neutral head is going to give us an equal limb length. So all this pre-planning is done. We don't even have to check it initially. We just do all this pre-operatively. Then we have a nice depiction of how the cup is going to sit. We can determine our 40 degrees of inclination and inversion depending on, if you want to increase it, you can. The transverse view gives us the right anterior posterior fit, and the sagittal and coronal views give us the right superior inferior fit as well. Restoration of the strip, center of rotation can also be done. If you want to medialize the cup or not, we can decide over here. The green dot is the cup that we have placed, and the pink is the native cup. If we determine that medialization by 2 mm is giving us a better limb length and a better offset, then we can do that as well. Then finally, the femoral component sizing, it will tell us two size 2 and 127 neck. There are two types, 127 or 132. And depending on whether we need to increase or reduce our length, we can change our head length as well. This even gives us a pre-operative visualization of the post-operative X-ray. And most of the time we find out that the X-rays are spot on. Just a small video of how this is done. The robotic arm comes in, and then the predetermined green part, as I showed you earlier, we have to just ream away. So we don't have to do sequential reaming anymore. And with robotics, we ream the acetabulum once, and the final prosthesis is also directly impacted without having to go for the trials. Okay, you can see over here, and it even shows us how much more medial we need to go, how much posterior, how much superior. We just ream away the green part of the bone, and in one go you're done. Your acetabular cup is completely ready for implantation. There it is. That's done. And then of course the proper impaction is also important. It even tells us how many more bangs we have to do to get the right cup fit, so that you make sure that you're not going to shatter the quadrilateral plate. If you notice here in the bottom right hand corner, this is a real time, and this is the real time depiction of it on the computer. And banging, it says I'm 5 proud, and then later now it's come down to 6, and now it's come down to 2. So it tells us how many more times you're supposed to hit to finally impact the cup. At the end of the day, it gives us a 3D representation of the surgical plan and the end result. And as I said, the X-rays, the cup version and inclination is always spot on compared to the pre-op visualization. What about the procedure time? It looks like it's going to take a lot of time because we have to do a registration of the points, we have to put in the arrays. But now we have found, because of the reaming time and the cup impaction time has reduced greatly, our time has actually not even become neutral, it haven't even become faster. So summary of the benefits in TCAR: accurate sizing, perfect gap balancing, 100% precise cuts, a partial knee replacement prevents overstuffing, and total hip replacement cup placement and avoids dislocations. Consistency and reproducibility every single time is what we have found in our patients. Now, if you ask what's the difference between robotics and navigation, I'll just briefly explain the advantages of robotics over navigation. First, of course, we have a 3D CT scan here. So it's an image-based robot. So there's accuracy of the bone registration and the landmarks. Here we can understand the pathology and the location of the osteophytes, bone defects, cysts, quality of the bone, and occult fractures, all before we even go into the case. Then there's the pre-op planning, which you can do again before entering. You can do accurate sizing of the femur as well as the tibia, the positioning, shape matching of the femur. We even restore the posterior condylar offset. Sagittal planning and patient-specific alignment can all be done beforehand. Of course, after that, the part where the navigation doesn't really help you is the well-defined haptic boundary. And there's lots of data from lakhs of CT scans from robotic around the world. The bony landmarks, robotics, you have, it's already the CT scan is given. So we just have to match these two landmarks in the femur and just show the rotation of the center of the hip. But in navigation, surgeon has to physically locate all the landmarks, and it's hence prone to error, which has been shown in literature as well. Bone registration in the robotics system already has a CT scan. So 40 points on both the bones is enough. It's a very, very high accuracy of less than 0.5 millimeters. In navigation, you have to actually paint the whole bone, and still it is prone to some sort of error. This paper by Sebastian Lustig shows that these three components, femoral posterior offset, tibial sizing, and femoral undersizing, there's a lot of deviation. If you see the green, which is very standard, is the robotic, the brown is navigation, and the blue is mechanical partial knee replacement. See how much of deviation is in these two, but in the robotics, it's very, very consistent. Then, of course, there's joint balancing, robotic versus navigation. Dynamic joint balancing can be done in the robotics. You can just put 2 degrees of tibia vara, 1 degree of varus in the femur, 1 degree external rotation of the femur, and you see how these gaps have been balanced out nicely. But in the robot, the cutting jigs need to be placed manually for all the cuts. It's time consuming, and it completely depends on the surgeon's dexterity. It cannot be reproducible every single time. So why is robotic superior to navigation? The final part, which is completely set apart from navigation, is a robotic arm assisted bone preparation. Here is where we're a cut above the navigation. As you can see, as I mentioned earlier, it auto aligns to the cut which we have pre-planned. And then we can go make sure we do our cut without staying outside of the boundaries. There's sub-millimeter cut precision. So if you just want to summarize that, navigation is only a planning tool like a map, a physical map. But a robot is like a GPS. It's going to tell you where to go, what is the speed, what is the weather, what is the traffic. It's going to tell you everything, and it helps you reach the target. And you can reach the target certainly without any doubts. This is only going to guide you, and you don't know whether you're going to end up there correctly or not. Once again, not all robotic systems are the same. Literature of one cannot be extrapolated to the other. I'm talking strictly about the Stryker Mako. There are other robots like the Rosa, the Navio, and the Cubis. And this is just a summary of the advantages. I'm not going to go into this right now. So if yes to robotics, then why Mako? There's so much of good data here. This is the only CT-based system. It recreates a 3D image of the patient's anatomy. It has an intelligent tool holder without any cutting jigs. It's the only system for all three primary applications. That's the partial knee, total knee, and the total hip. It has the haptic technology combined with the 3D data. And there's many years. Actually, now this is more than 1,000 systems around the world. But what does it mean for the patients? At the end of the day, the patient's satisfaction is more important than anything else. So less pain in the 90-day post-op period is what has been found. Robotic versus manual. 92% patient satisfaction at 2 years, and that's again more than the conventional. Sorry, everything is less over here. Less bone and soft tissue damage, less need for analgesics, less time to discharge, less post-operative pain. Again, the accuracy and in the femoral component and the tibial component is much more compared to manual partial knee. And we have also summarized our advantages in this particular slide. You can just take a screenshot of this. Our journey with Mako was first we launched our Sunshine Orthopotics department. It was inaugurated by PV Sindhu. She used the robot for the first time on the sawbone. And right now we are standing at 1,205 social surgeries in spite of 2 lockdowns. And majority are total knees. We have done, now we're increasing our numbers in partial and hips as well. So what about our outcomes? That's what matters. This is a Mako unicorn led. It's the very second day after surgery. She's walking, not only walking absolutely normally, but also able to sit and squat and speak to us without any pain and without any problem at all. And this gentleman, this is 1 week after bilateral partial knee replacement, going for a walk in his garden. Day of surgery itself, this gentleman is able to do his straight leg raising. This is probably because we are doing very, very little amount of soft tissue release. And this is probably, we're not changing the myointerior of the knee joint. Gross deformities can also be taken care of by the robot. Perfectly nice, straight joints with perfect balancing. Valgus deformities have also been corrected by us. This is a severe valgus deformity, which we managed to get nice and straight just by using the robot and doing the balancing. This is a bilateral total hip replacement for 37-year-old woman. This is 1 month post-op. And this is our first batch of robotic patients that we had done. So why are we getting better results? It's not that the robot is some God's gift or something suddenly come from out of space and helping us. Basically, the reason is we are maintaining the internal homeostasis of the knee, titration of the bone cuts. So we are getting functional alignment. So that leads to less amount of ligament release and indirectly less amount of pain. The haptic control, there's less inadvertent soft tissue injury, and there's less time with the knee subluxated. We don't need to subluxate the tibia until the tibial preparation now. Even while doing the tibial cut, it's all done without subluxating the knee. Our study, we're doing a study where we're doing a double-blinded randomized control trial comparing patient satisfaction, one side robotic and one side conventional, to see which one has more comfort. And right now we're more than 80 cases, around 95 cases we have recruited. And we're going to see how the 1 to 2 year follow-ups are doing. The future of robotics, especially Mako, the hip is going to show, the upgraded software is going to give us more information about impingement and spinopelvic abnormalities. And they're going to come up with the shoulder replacement as well in the near future. Thank you so much for the opportunity.